we move on to the next presentation. Dr. NINAN Jacob, our retinal pigment epithelial analysis in acute VKH.
Good afternoon, everyone. My name is NINAN Jacob. I am a veterinary retinal fellow from L. Prasad Institute, Vijayawada, and I will be presenting our paper on retinal pigment epithelial analysis in acute VKH disease. So, as we all know, VKH disease is an autoimmune multi-system inflammatory disorder directed against melanocytes with ophthalmic, neurologic, otologic, and dermatological manifestations. In the eye, it presents as granulomatous posterior and panuveitis with diffuse choroiditis, vitritis, serous retinal detachment, and cystoid macular edema. Though the diagnosis is practically clinical, we can use FFA, ICJ, and OCT for confirming our diagnosis. So, objective of our paper was to assess the morphological features of the retinal pigment epithelium during the acute phase of disease and following its resolution, and its probable role as an OCT biomarker during the acute stage of VKH disease. This was a retrospective observational single-center study conducted between 2016 to 2021, which included consecutive cases of acute VKH disease, and we excluded other cases of coexisting retinopathy and other causes of diminution of vision. The data collected include the demographic data, the best-corrected visual acuity, duration of symptoms, and the duration of disease. The retinal pigment epithelial characteristics which we analyzed included the RPE reflectivity and the RPE thickness, both during the acute phase and following resolution. We also collected the total choroidal thickness, the central macular thickness, and analyzed certain morphological features of the RPE and the choroid during the acute phase and following resolution. We use the Topcon Triton Swept Source OCT for image acquisition, and for image analysis, we use ImageNet software for measuring the central macular thickness and the choroidal thickness, and the open access software ImageJ for measuring the RPE reflectivity and RPE thickness. So this is a representative image of how we measured the RPE reflectivity. Using the oval selection tool in ImageJ, we selected our area of interest on the RPE to measure the overall RPE reflectivity or the mean gray value. We measured RPE reflectivity from 3 locations and then averaged it. And we measured the reflectivity under the fovea, under areas of attached retina, and under areas of detached retina during the acute stage and following resolution. And this was how we measured the RPE thickness using the inbuilt caliper of ImageJ. For data analysis, we converted the Snellen visual acuity into the logMAR, and a two-tailed paired t-test was used to analyze the variables pre and post treatment. And the Pearson correlation and linear regression analysis was used to assess the relation between the various different continuous variables, and a p-value of less than 0.05 is considered significant. Our cohort included 29 eyes and 29 patients and 55 eyes, and we excluded 3 eyes because of poor image quality. We had 9 males and 20 females, with the average age being 33 years, with the range ranging from 9 to 57 years. And the mean duration of symptoms prior to presentation was around 15 days, and the mean duration of disease was around 90 days. In our results, we noticed that there was a significant improvement in the best-corrected visual acuity following resolution, and as seen in other studies, there was a significant decrease in the central macular thickness as well as the subfoveal choroidal thickness. What was new in our study was that there was an overall increase in the RPE reflectivity following resolution, more clearly seen in the area under the fovea as well as area under the detached retina. Also, we noticed that the RPE thickness decreased following resolution in all areas, that is under the fovea, under attached as well as detached retina. On correlation analysis, we noted that during the acute stage of the disease, the RPE thickness under the fovea correlated with the subfoveal total choroidal thickness. Also, there was a correlation between the baseline BCVA and the duration of symptoms, as well as the final BCVA and the duration of the disease. However, we could not find any correlation between the RPE reflectivity and thickness during the acute phase of the disease and following resolution, nor could we find any correlation between the change in the RPE thickness or a change in the RPE reflectivity with the change in BCVA following resolution of the disease. So these are some of the morphological features we noticed. So in this image, we can see in the inset what is marked with the red asterisk as tiny hyporeflective lesion within the RPE, which are these RPE vacuolations. We presume that these RPE vacuolations occur due to increased inflammation and edema of the RPE. This was seen in around 15 eyes of our study cohort, and all of these resolved after treatment. Another interesting feature which we noticed in our study cohort was these well-localized hyperreflective lesions on the RPE seen in eyes following resolution of the disease, seen but only in 3 eyes. The choroidal hyperreflective dots are these well-circumscribed lesions within the choroid, seen in around 85% of the eyes during the acute stage, and all these resolve following resolution of the disease. And in a patient cohort, almost since even though the vision improved in all our patients, a lower baseline best-corrected visual acuity, a higher baseline total choroidal thickness, shorter duration of symptoms, the increased thickness of the RP under the detached retina, the presence of bacillary layer detachment, and the presence of hyperreflective choroidal dots showed a greater improvement in visual acuity. But on multivariate analysis, only a lower baseline BCVA and the presence of bacillary layer detachment at baseline showed a significant effect on the final improvement of BCVA. So to conclude, we propose that the RP thickness and reflectivity can act as surrogate biomarkers of choroidal activity and inflammation in acute stage of disease, especially in conditions where due to the intense inflammation, we may not be able to assess the choroid due to poor image quality. And then we noticed that RP vacuolations and choroidal hyperreflective dots are novel OCT features seen in our cohort of PKH patients. Thank you.
In one of the photographs, you showed that RP thickness was increased because of some depositions. So it could lead to false measurement like this. So
we excluded this area, sir. This was just an image finding we noticed, but and this is seen only in 3 eyes. So we excluded this to prevent any outlier value.
So what I wanted to know is that if you look at the mean duration of your symptoms in your patients, it's almost 15 days. That's too high for a patient to be having with acute VKH. Now, did you look into categories of patients who are presenting to you within 3 days, 3 to 7 days, 7 to 14 days, 14 days and beyond, and then look at the RP reflectivity and the thickness in those patients, because that will actually give us a true picture?
That analysis we actually didn't do, sir. Like based on the duration of symptoms, we didn't categorize the patients.
Also, you said that there is no change in the reflectivity from acute stage and when you followed up the patient up when the disease became quiescent, isn't it?
No, ma'am. I told that the reflectivity of the RP decreased significantly, decreased following a resolution.
Okay. Well, just go to your next slide. Next one.
What I mentioned here was that
resolution.
there is no correlation between the reflectivity and
correlation.
thickness.
Yeah. So then your result means your conclusion doesn't.
No, ma'am. There is no correlation between the reflectivity and thickness. But what we are proposing is that the thickness of the RP increases during the acute stage, and because thickness is increasing, we assume that it is due to the edema of the retinal pigment epithelial cells, and because of that edema, the reflectivity decreased. And following resolution, when the thickness decreased, the reflectivity is again better following resolution. And there was no discrepancy in the image quality, because during the acute stage and following resolution, what the image quality which we obtained from the OCT machine, there was no significant difference in that also.
good. Got something new to learn. RP vacuolations and thickness. So now we move on to the next.
Thank you.
Thank you.
Dr. Rashri, ocular granulomatosis, polyangiitis, a case series.
Now, did you look into categories of patients who are presenting to you within 3 days, 3 to 7 days, 7 to 14 days, 14 days and beyond, and then look at the RP reflectivity and the thickness in those patients, because that will actually give us a true picture?
That analysis we actually didn't do, sir. Like based on the duration of symptoms, we didn't categorize the patients.
Also, you said that there is no change in the reflectivity from acute stage and when you followed up the patient up when the disease became quiescent, isn't it?
No, ma'am. I told that the reflectivity of the RP decreased significantly, decreased following a resolution.
Okay. Well, just go to your next slide. Next one.
What I mentioned here was that
resolution.
there is no correlation between the reflectivity and
correlation.
thickness.
Yeah. So then your result means your conclusion doesn't.
No, ma'am. There is no correlation between the reflectivity and thickness. But what we are proposing is that the thickness of the RP increases during the acute stage, and because thickness is increasing, we assume that it is due to the edema of the retinal pigment epithelial cells, and because of that edema, the reflectivity decreased. And following resolution, when the thickness decreased, the reflectivity is again better following resolution. And there was no discrepancy in the image quality, because during the acute stage and following resolution, what the image quality which we obtained from the OCT machine, there was no significant difference in that also.
Good. Got something new to learn. RP vacuolations and